Good evening, everyone, and welcome to the Canadian Concussion Center's webinar series, which is sponsored by LiUNA, the Laborers International Union of North America. My name is Leslie Rattan, and I'm really pleased to be moderating our webinar series, which was developed for individuals that are struggling with persistent symptoms post-concussion, as well as their family, friends, and healthcare providers as well. If you've been with us before, you know that our sessions are recurring every other Tuesday evening from 6 to 7 p.m. We have one outstanding for this session, and then we'll be taking a break for the summer. And just so you know as well, if you ever want to rewatch or watch a webinar that you missed, you can find those on the Canadian Concussion Center website. And I suspect Christian will put those into the chat, the link to that. So each of our sessions focuses on a different topic or symptom related to concussion, and we are really fortunate to have expert speakers with us that usually present for the first half of the session, and then we open it up to your questions and answers. So if you haven't been with us before, when you look at the bottom of your screen, you'll see that there is a chat function. If you're having any technical difficulties, please enter your problem or question there, and Christian can help you out. If you have questions for our speaker tonight, please enter those into the Q&A box below. So just before we get started, we're going to just run our quick poll, which is helpful for us just to get a sense of who is in the audience. So I'm going to have Christian pull that up and give you a second just to indicate which category you fall within. Perfect. Thank you. So for this evening's session, I'm really pleased to introduce Leslie Birkett, who is back with us again, and she's going to be presenting on return to work, vocational rehabilitation, and occupational therapy. Leslie graduated from Queen's University in 1987, and she's worked for over 30 years in brain injury rehabilitation with both children and adults in settings ranging from acute care to the community. Leslie has operated her own private practice since 1995, and in addition to her clinical work, she's an adjunct assistant clinical professor in the McMaster University Faculty of Health Sciences Occupational Therapy Program in Hamilton, Ontario. She's also a hub member of the University Health Network's Project Echo Concussion, and Leslie is the co-author of the I-CAN assessment, which is a community-based evaluation of executive functioning. Leslie enjoys collaborative, community-based rehabilitation using a participate to learn approach. She thrives on situations that challenge her creativity and use of best practices, and strives to assist her clients with meeting their personal life goals. So I think you're really going to enjoy this. I'm going to turn it over to Leslie.
Thank you, Leslie. I'm just going to share my screen. All right. Is that looking okay from your end?
Yes, looks good.
Okay, thanks. All right, so I'd like to thank Leslie for the introduction and thank the Canadian Concussion Center for asking me here tonight to speak to you about return to work following concussion, and that's a topic that I'm quite passionate about. So for today, the learning objectives. So by the end of this session, participants will be able to name the typical difficulties associated with return to work and describe ways to combat and/or accommodate the difficulties. So the first learning objective is to name the typical difficulties associated with return to work. And while the vast majority of individuals do return to work following concussion, studies do vary widely. In a 2018 meta-analysis of return to work following mild traumatic brain injury, the authors of the article cited on the slide found that 50% had returned to work after 1 month and 80% after 6 months. So of course that means that 20% of individuals had not returned to work half a year post-concussion. And in this study, the authors identified that the more complicated the neuropsychological profile, the more the return to work period is extended. Now, part of the reason the research varies widely and is so messy is based on the diagnosis of concussion that was used in the research, as well as the definition of work. So this might sound strange, however, returning to work is not a binary yes-no issue. The question with the definition of work relates to what did the study actually consider? So did they look at starting back to work? Did they look at returning to the same job? And how long did they follow the subjects? Because employment stability is of concern with this population. So in a more recent 2020 article in Brain Injury, the authors also pointed to the need to identify what is meant by return to work. So the confusion appears to just continue. And there are a variety of factors related to employment status post-concussion, and different researchers focus on different factors. So for example, in 2006, Nolan and Haru only looked at the initial symptom load. And as expected, they found that the total number of symptoms reported was related to eventual vocational status. Now, in a 2023 Norwegian study by Fuhr and colleagues, the authors informed that there's relative consensus regarding the importance of factors such as age, injury severity, and premorbid psychiatric problems as predictors of work outcomes. And those are the ones that I've checked off there on the slide. They also found that a higher initial symptom burden was negatively associated with work participation. So the variety of factors that are listed on this slide come from a study by McAmmer and colleagues in 2005 that considered employment stability. And the authors found that injury severity was more predictive of the person returning to work, and factors relating to the nature of pre-injury employment were more influential in the maintenance of employment over time. So we can see that these authors found that pre-injury employment status, severity of injury, age, level of education, injury-related physical impairments, cause of injury, cognitive impairments, behavioral and emotional difficulties, comorbid psychiatric diagnoses, and environmental factors such as social and rehabilitation support were all associated with return to work. And the research that I'm finding of particular interest, such as a study by Watkin in 2020, informed that injury severity alone does not explain the extent of return to work, but psychosocial and employment-related factors may be key determinants of work outcome. And we'll talk about that a little bit more. But let's take a closer look right now at some of the factors that have been studied. So we know that fatigue is a common complaint following concussion. And a group of Chinese researchers evaluated just over 100 individuals with a first traumatic brain injury who were more than 3 months post-injury. And they found that recognition memory and processing speed correlated to return to productivity. And importantly, the results identified that these associations can be partially attributed to mental fatigue even after adjusting for major covariates such as age and gender. So this is really important to consider as a complete evaluation of fatigue and consideration of effective treatments for managing fatigue are recommended approaches for concussion management. And what about pain? Well, pain, including post-traumatic headache, is known to be linked to long-term outcome following TBI, with headache one of the most common symptoms following concussion. And additionally, post-traumatic headache has been shown to compromise cognitive functioning following concussion, which that in turn has been shown to predict return to work. So in a Canadian study of over 100 participants, these were people who were recruited from an outpatient center in British Columbia. The researcher found that headache was significantly associated with return to work and that headache negatively affects return to work. And so again, we see another typical post-concussive symptom that's been linked to poorer outcomes, specifically return to work following concussion. And our messy theory remains proven. And as a reminder, you've previously in these Canadian Concussion Center webinars, you've heard that treatment of symptoms is critically important to improving functioning, including return to work. So more generally, the information on this slide is from the Brain Injury Guidelines website, and we can see on this slide factors that influence recovery. So thinking about some of the ones that I picked off of this slide are symptom load, age, education, cognitive impairments, particularly memory, stress and anxiety, compensation seeking, and pre-existing mental health difficulties or a previous brain injury. And so again, I point those out because we can see a significant overlap with the factors related to employment status that I've previously mentioned. So the brain injury guidelines state that regarding return to work, to encourage patients to return to some form of work, so long as the work does not place the person at risk of re-injury. We want to facilitate identification of necessary restrictions where there's risk of re-injury and appropriate accommodations by clearly identifying patient symptoms and functional limitations in realms of physical, cognitive, and emotional. And we are going to return to look at those definitions in a few minutes. So we've talked about factors related to outcome, and what about barriers to returning to work? Well, barriers are similar and can include things such as cognitive factors, so thinking, concentrating, understanding, remembering, planning, organizing, and multitasking, fatigue, persistent symptoms that affect the person's ability to do their specific job, the invisibility of the injury, and lack of advice and guidance on return to work. So thinking about the cognitive barriers, let's take a glimpse of our current world of work. And we can look here on the slide at typical skills necessary for jobs in today's world. And the information on this slide is from job ads on ZipRecruiter. And we can see skills such as organizational skills, the need for excellent communication skills, the ability to be able to multitask, the ability to collaborate or work well with a team, the ability to demonstrate professional behaviors with customers, the ability to manage a fast-paced work environment, to learn, and to be self-motivated. So essentially, many higher level cognitive and executive functioning skills are necessary to survive in today's work world. And this is why return to work is so tricky. The brain injury guidelines identify that evaluations, if necessary, should focus on executive functioning, attention, memory, information processing, and verbal skills, as these were found to increase the likelihood of successful return to work. And we can see from these job ads why that makes sense. So the goal of the return to work plan following concussion is to enable the worker to fully participate in work tasks. So we want to maximize work capacity while remaining below symptom exacerbation threshold levels. So to summarize, our first learning objective was to name the typical difficulties associated with return to work. And in a 2014 paper by Vulgis, Iverson and colleagues, they noted that the risk factors for poor outcome and specifically delayed return to work after concussion are diverse, complex, and not well understood. I don't want to finish there because it's important to consider what helps and what we know is support from family, friends, and treatment team, as well as employers who provided accommodations, are beneficial factors. And we are going to talk more about accommodations as we move forward. And so the second learning objective is to describe ways to combat and or accommodate the difficulties. Sorry, that slide is not advancing. There we go. So why? Well, employment is an important determinant of health. And for workers, the literature demonstrates that brain injury patients who are employed report better health status, improved sense of well-being, greater social integration within the community, less usage of health services, and a better quality of life than those who are not employed. And when? Well, most people can begin the return to work process within the first few weeks post-injury. So the brain injury guidelines state that after a brief period of rest during the acute phase, so 24 to 48 hours after injury, patients with concussion should be encouraged to gradually resume normal activity. So that includes activities of daily living, work, school, duty, and leisure. And this should be based upon the person's tolerance as long as the activity does not pose a risk for concussion. So workers with symptoms that are present but do not change with an increase in work and work-like activities can begin to transition back to work. It's important to note that it's not necessary to be symptom-free to return to work. So if possible in the specific situation, for those individuals who are able to begin an early return to work, you want to consider beginning with full-time hours with progressive duties to minimize workplace disruption and most rapidly rebuild the patient's routine. The current evidence indicates that a graded resumption of regular pre-injury activities is tolerated, so in a manner that does not result in a significant or prolonged exacerbation of symptoms, within the first few days to weeks post-injury should be encouraged because regardless of symptomatic status, activity is more likely to speed up rather than delay recovery. So I want to highlight some literature regarding the importance of early return to work. And as I stated earlier, the literature is quite inconsistent in terms of the length of time to return to work that's typical following concussion. So the graph on this slide is from the 2014 Volges, Iverson and colleagues study of the Finnish patients. And of the 109 patients that they studied, one can see their rather rapid return to work, with over 50% having returned within the first 2 weeks and 94.5% having returned by 11 weeks. So the researchers noted significant differences in return to work rates, in studies from different countries. And they noted that past researchers have reported that people who have expectations that their symptoms will resolve quickly actually have shorter recovery times. So this points to the important role of patient education, which we know in and of itself is a form of treatment. And this should occur from the immediate time of injury and ongoing. And here's another graph, and one can see a very similar picture to the previous one. And again, this highlights the importance of early return to work based on the number of people who return after the 6 to 12 week mark. So we can see the line that curves up along the top is the percent of patients who return to work. And the line along the bottom that scoops down the bottom is the probability that the person will return to work within the next week. And the diagonal line is the probability of someone ever returning to work. So there's a short window of opportunity to renormalize life for the majority of individuals post-concussion. And that being said, there's still hope for those who don't return in the initial period, because these are the individuals that occupational therapists typically see. So from the brain injury guidelines, this algorithm is available to download. It's a decision-making tool regarding the return to work process, and this will be really helpful for primary care providers. It includes specific questions regarding the demands of the job, safety concerns, and suggestions for when to consider a vocational evaluation. Again, it's important to note that the existence of symptoms at baseline is not in and of itself a basis for no return to work. So prior to returning an individual to work, it's important to understand the worker's rights. In Canada, disability is a protected ground against discrimination and harassment. With that in mind, and provided it's safe to do so, in most cases, the employer has a duty to provide reasonable job accommodation for the employee to the point of undue hardship. Specifically in Ontario, in general, legal protections for workers fall into 4 broad areas: fair treatment at work, protection of health and safety, duty to accommodate, and income replacement. And under the Canadian Human Rights Commission, an employer has the duty to accommodate. It's important to recognize that sometimes people need to be treated differently in order to be fair to them. And I'm sure this slide is familiar to many. It demonstrates the concept of equity, meaning that sometimes we might need to be given different things to be equal, and therefore alternative arrangements might need to be made to ensure the full participation of the worker. So what does the return to work process look like? Well, we want to aim for a gradual, progressive process. The Institute for Work and Health has published various resources on the topic of return to work. And I've found that their evidence-based practical resource actually aligns very closely with the process that I follow for those with prolonged symptoms. So key points include the development of an individualized return to work plan, to ensure communication with the workplace, to hold a return to work meeting with key stakeholders, and to recognize that the return to work process may not be linear, and of course to maintain confidentiality. And who might these stakeholders be? Well, we would want to consider, of course, the worker. It's important to see if the worker can identify a co-worker who might be a source of support for that individual in the work environment. It's important at any return to work meetings to include the manager, because of that, of course, that person will be responsible for assigning work tasks and evaluating the employee. And human resources can play an important role at any return to work meetings. They can clarify company policies, and they may be the direct link with the extended health carrier if required, and possibly a union representative. And what about the process? What are our roles? Well, the healthcare professional identifies the medical restrictions, identifies the limitations, physical, cognitive, and psychosocial emotional, and identifies and documents the symptom triggers. And the employer, it's their role based on the information provided by the healthcare provider to review the job demands and determine the type of work available and whether the patient can be accommodated. And the employer and worker formulate the return to work plan. I have often found that if the plan provided by the healthcare professional and the worker is detailed enough, that the employer will tend to accept it as it is. So let's go back and look at some of the specific terms that I've mentioned. So restrictions. Restrictions are needed if there's a risk of harm that encompasses any situation where performance error in a physical or decision-critical task could result in injury to the worker, co-workers, or the general public, and/or disruption of equipment, production, or the environment. So for example, for someone with a balance impairment, of course, a restriction would be no working on ladders or at heights. And for someone with impaired concentration, there might be a restriction of no operating heavy equipment or potentially no driving. And limitations. So these are activities that the patient physically, psychologically, and/or cognitively is unable to perform, but they may not pose a risk to the worker or others per se, but would reasonably interfere with the ability to perform a given task. So for example, with headaches, we might suggest that the person avoids heavy or repetitive lifting or limit their computer time. With irritability, we might suggest that customer service is avoided. With photophobia, we might suggest that they avoid brightly lit environments, avoid fluorescent lighting, limit screen time. And with intolerance to noises, we might suggest use of noise canceling headphones. So the limitations are linked to the symptom triggers. So for example, the headaches that are caused by excessive computer use. The headache would be the limitation. The accommodation would be to decrease computer time, use an anti-glare screen, or ask for an ergonomic assessment of their computer station. So what about the difference between graduated hours and graduated duties? And for primary care providers dealing with those individuals that are returning to work early post-injuries, you'll want to consider this differentiation. Ideally, you'll want to be able to review a copy of the person's job description in order to assist with decision-making. It's important to decide on a case-by-case basis the plan. In most cases, however, you want to look at full-time hours with progressive duties. This is considered optimal because it provides the best opportunity for active rehabilitation. It rapidly reinstates the patient's routine. It helps improve self-esteem, and it minimizes workplace disruption, which can strain psychosocial relationships in the workplace, which then might pose new barriers to return to work. So this might look something like in week 1, 2 hours of regular duties and 6 hours of modified. In week 2, 4 hours of regular duties and 4 hours of modified. So it's important to remember to combine this with ongoing patient education regarding symptoms and expected positive outcome. And what about those who have prolonged symptoms? Well, as a reminder, more recently, those are considered individuals with symptoms at 1 month post-injury. And estimates vary. However, a small percentage, perhaps 15 to 20% of individuals, will go on to suffer prolonged symptoms beyond 1 month. And for persons with prolonged symptoms at 1 month post-injury, referral for specialized assessment and/or interdisciplinary concussion services or clinics might be indicated. And so these are the patients that I see as an occupational therapist, and return to work still is possible. And I've had some patients return even after a year off the job. And for these patients, the return to work process can look quite different. So when I develop a return to work plan, I always do so in conjunction with the worker, as they're the expert regarding their job duties. And as I mentioned, I find if we're thorough and detailed, that the workplace will typically accept the plan as it's written. And on the screen is a sample of the type of information that I include in any return to work plan. So for example, for fatigue and headaches, the accommodations might be part-time graduated return to work. The person might require intermittent work breaks between tasks and extra time for task completion. We might want to note that both physical and cognitive activities can cause fatigue. We may request a private or quiet office and avoid heavy lifting. So for someone with irritability, we might suggest reduced coworker interaction. With difficulty tolerating bright lights and computer screens, we might recommend natural lighting and a desk lamp, and maximum of 1 hour computer work followed by a change of task. And for reduced concentration, we might suggest the person complete one task at a time and avoid multitasking. We might identify that single task assignments with additional time for task completion is necessary. And we may recommend the ability to work from home 1 day per week. And this is one of the COVID silver linings, that this accommodation is much easier to obtain nowadays. So the proposed steps would be the next thing I identify. So this person was going to return to the office the week of May 3rd for 4 hours per day, 3 days per week for 4 weeks. They were going to have flexible work hours starting at 10 a.m. and reevaluation prior to a planned increase in hours on May 31st. So often with the patients I see, I find that the increases in work hours may take 4 to 6 weeks initially and perhaps ongoing. So the question is when to increase hours. And we know that symptoms tend to increase with increased activity. So I look for symptoms returning to baseline before increasing hours. And this needs to be a flexible and fluid process, similar to what I discussed when I was talking about the work and health document. And the patient needs to be therefore aware of his or her baseline level of symptoms before beginning the process, meaning how long can they do a task before symptom exacerbation. So it's important to note that the specifics in the plan have been determined as best as possible through trial. So for example, the 1 hour of computer work was determined through a detailed history with the patient trialing this at home. And I always try to mimic work tasks prior to returning to work. So for example, for anyone who needs to take minutes at a workplace meeting, you could have them trial taking notes during the evening news. So it's critical to ensure planned follow-up with the worker in order to evaluate what's working and what's not working and make any necessary changes and adaptations. So in a study by Theodem et al., they identified that 1 in 5 individuals with a concussion struggle to meet the demands of their work over a longer term. And this study followed these individuals for 4 years post-injury. They noted that these individuals may exit the workforce or participate with reduced work hours, and this may point to the need for long-term accommodations. This study found that cognitive impairments, especially taking longer to think and poor concentration at 1 month post-injury, may help predict who struggles and who may benefit from early intervention. So in a 2020 British retrospective analysis of over 170 patients with varying severity, so this was the range from mild to severe of brain injury, the researchers found that at 1 year post-injury, nearly a quarter of the participants continued to have work accommodations. And you can see that the accommodations included things like a phased return to work, more work breaks, reduced workload, less responsibility in the workplace, more supervision, the ability to work from home, and outside help. Fearing colleagues from Norway also added that a predictable work schedule was found beneficial. So while the literature indicates that accommodations are temporary, interventions to facilitate the retention of return to work should be considered upon re-entry to employment. And the British study, their findings indicate that support from employers may be necessary for longer periods following a return to work after a concussion. They hypothesized that this could be explained by the nature of brain injury not being understood initially. So with sequelae, so for example, like poor concentration and slower reaction times and fatigue, impacting on productivity, and meaning that many adjustments need to be made several months after returning to work. So they said that it's plausible that adjustments implemented initially may not be reviewed, raising questions about the importance of accommodations for job retention. They felt that future research must investigate the value of accommodations and establish how long these are used or if they're required indefinitely. And the longer-term study, the Theodem et al. Study that occurred in New Zealand, the researchers found higher rates of unemployment at 4 years post-injury when compared to the general population. So they noted that ongoing accommodations that they noted in the study included increased use of note-taking, more time to process information, increased sleep rest breaks to manage fatigue, reduced working hours, and a change in work style might be required. So it's important to think about the accommodations that might be necessary for success. When we think about return to work, it's important to consider the vicious cycle that you've been exposed to during these webinars. So essentially, when someone has a concussion, they experience symptoms and these symptoms interact. So for example, the cognitive symptoms that cause the person to feel anxious, this leads to muscle tension, which can cause headaches, which in turn can affect attention, leading to cognitive symptoms. So to prepare the worker, it's really important to treat the symptoms and for therapists to consider a variety of strategies to help the worker. In a 2016 systematic review in brain injury, the researchers found strong evidence that interventions containing a combination of work-directed components, so that would be, for example, like adapting work tasks, and education and coaching, so like emotional support, were effective strategies to help with return to work. The authors noted that paying attention to both the workplace and the employer were important considerations. And as a therapist, I think it's important to review the use of strategies, which would be the adaptation of work tasks. You want to ensure that your client is using tried and true strategies and that the strategies have been practiced and are reviewed and tailored to the individual's work tasks. So we need to consider strategies for physical symptoms such as pain and headaches and fatigue, strategies for cognitive symptoms such as attention, concentration, memory, and processing speed, and strategies for emotional symptoms such as anxiety and irritability. So what might be some strategies that are applicable to work? Well, you can have individuals do things like create to-do lists, develop templates or flowcharts for work tasks, use mind maps to break down projects. I often have workers write a list of the top 3 tasks to complete, and I have them sometimes do this at the end of a work shift so that when they go in for the next work shift, they know where to start. That's particularly important if they have a day off between shifts so that they keep on track of where they are. I've had people set an appointment time with themselves for uninterrupted work time. We often talk about getting a good night's sleep, so reviewing sleep hygiene and addressing that's important. To take task breaks, and I always say, of course, no one monitors how often you go to the bathroom or what route you take to get there. To incorporate task changes, to integrate energy boosters, to implement deep breathing or mindfulness techniques for stress and anxiety, to consider an ergonomic evaluation of the work environment, to be prepared, because as one of my clients famously said, failing to plan is planning to fail. And for metacognition, training of formal problem-solving strategies and their application to work tasks is identified in the literature as beneficial. So it's important to follow up and discuss the specific work tasks that are proving to be challenging to the worker, and then to develop and apply specific strategies. So I did want to highlight this best practice resource from the Brain Injury Guidelines. This is for individuals who are considering returning to work following a concussion. It provides some general ideas to consider regarding return to work, some information about symptoms at work and how restrictions and accommodations might work, and it provides some additional resources. I also wanted to showcase this resource from British Columbia. It contains some simple and practical resources. So for example, the orange chart that you see there is a guideline for progressing tolerances to support return to work. Well, what about kids? So teens should prioritize returning to school because this is their main job. And following successful return to school, which usually means with a full course load and no accommodations, then we would look at returning to work. And many kids might need help prioritizing. School, then what? Sport, work, leisure, friends. And kids also may need help to advocate with their employer and consider job accommodations and modifications. So finally, we would be remiss without considering those individuals for whom return to work is not possible. So when prolonged post-concussive symptoms pose a barrier to return to pre-injury employment, introduction of other meaningful activities that facilitate recovery should be considered. So other employment, full or part-time, educational activities, community roles, and activities that promote community integration, such as volunteer work, may be considered as an alternative focus for meaningful activities. And what are the wrap it up take home points? So we know that work has many benefits for the individual. The goal of the return to work plan is for the worker to fully participate in work tasks while remaining below symptom exacerbation levels. Return to work plans must be specific and include restrictions, limitations, and tolerances. Complex cases may require vocational evaluation. And if symptoms preclude return to work, consider an alternative focus for meaningful activities. And then at the end, you'll see that I've included some references and resources for you. So I am going to stop sharing my screen. There we go.
Hi there, Leslie.
Hello.
So just a quick heads up, I'm sure you've noticed Dr. Rattan is not in the room. Her computer just crashed on her. So what I'm going to do, I see we have Dr. Tatter in the audience. I'm going to promote him to panelist, and if he will join us to go through some Q&A, that would probably be helpful.
Sounds great.
I think he'll be up here in a moment. Hi there,
Great.
Dr. Tatter.
Hi.
Hello. Sorry, I can't get for some reason it's not allowing me to start my video.
Oh, one
Leslie,
moment, I can.
can you hear me?
Yes. Oh,
Great.
there we go.
Hi, Leslie. Well,
Hi
that was
there.
very, very good of you, and thank you for that very comprehensive review of what's important. And let's see if we can start with some of the questions that are in the chat. So the first question is, Mike is asking, if a person has been off work for 5 years due to a TBI, what is the rate of return to work?
Well, that is an excellent and difficult question. So I can't specifically identify the rate at 5 years, but we saw from the couple of graphs that I put up that certainly after 1 year, it is very, very small. So I think we can extrapolate that at 5 years, it would also be very, very slim. Never say never, doesn't mean things aren't possible, but the chances would be very low, I would think, unfortunately.
Thank you.
Mhm.
Leslie, I have a question. In one place in your talk, you said that you would rather have a person return to work full hours, but the work should be accommodated essentially to what the person can do. And then in another place, you said that if it's not possible to do full hours, then we would do partial hours. And so can you just review when it should be a full hour return to work and when it should be partial hour return to work?
Sure, thanks. That's a really good question. So when we're talking about returning out of the gate with full-time hours, those are the individuals who would be returning to work very shortly following the concussion. So that is the majority of individuals, and those individuals are going to be seen by their primary care provider. So they're not going to make their way to my doorstep, for example. So when we get into individuals with prolonged symptoms, those are the individuals who typically need a more gradual process. And so that's the differentiation that I was hoping to make there.
I see. So somebody's been out for 6 months won't be able to go back likely at full hours to start with.
Yeah, not likely. Usually if someone's been off work for 6 months, I mean, it would be dependent on many factors, but typically at that stage, you would be looking at a more gradual reintroduction to the workplace.
Actually, that sounds fine. Leslie Rattan, I see you're back in action.
My apologies. I have had
No
one of
problem.
those days. Thank you very much, Dr. Chatter. I'm so glad that you're in the audience.
My pleasure.
Okay, let me see. So do we have some more questions? We have a question, Leslie. What is your experience with employers' support for long-term accommodations? And when will a patient know whether they need long-term accommodations at work?
Yeah, so those are great questions. So in my experience, if the employer has accepted the accommodations, I haven't had difficulty with having the accommodations continue. And I have had some individuals who have had accommodations for a long time who I do check-ins with down the road, and they are still using accommodations. So for example, a professional that I'm working with who prior to injury worked over 40-hour work week and now is back at their job full time, but needs to maintain at 40 hours. And we consider that to be permanent. So the question in terms of when do you know, that's a really great question also. I think when someone gets back to work full time, they can always try reducing accommodations, but if that makes the work more challenging, then we find that we leave the accommodations in. So I usually say to people that these are strategies and tools that will help you. And if you no longer need them, you may find that you just start automatically dropping them. So if you have been using some kind of let's say a flow chart for a work procedure, and you find you don't need to reference it, then you're you just automatically stop using that accommodation. So it's a little bit of an organic process, I would say, but certainly what the literature is pointing to is that often people do need accommodations long term.
Oh, that's great. Thank you very much.
Hmm.
Any other questions? I apologize. I missed the last questions. I know there had been one, Leslie, and you may have already answered this, but if someone is looking for an occupational therapist to assist them, do you have any recommendations in terms of where they should go to do that?
Yeah, so you could look at, there is a Find an OT website, which I do believe is associated with, I'm trying to remember, it's with our, I believe it's with our provincial association. I'm sorry, that's not popping up right in my head right now because I don't often find myself searching for an OT, but that's the Ontario Society of Occupational Therapists. So you could always go and check their website, and I'm pretty sure they're the ones that have a Find an OT. And if not, you could contact them and ask them for help. Certainly, you know, one of the things, again, about COVID that has been helpful is that many different OTs now are able to practice virtually. So it means that even if you're in a small community, perhaps in Northern Ontario, you may be able to access someone who's not in your immediate community who has the experience that you're looking for. So I think that's been really beneficial.
Yeah, that's excellent to know, and certainly, yeah, widens the opportunity for people. And typically, just this is a question for me, how long do you typically work with someone who, you know, if you were assisting someone in the return to work process?
That's a great question, and I would say it's hugely variable. I had one fellow this past winter who really just did a one session consult to help him get on the way. And I've had people who I've seen 5 or 10 sessions, and then I've had people who continue to request to check in, as I mentioned, like sometimes years down the road. So it's very variable. And I think it depends on, you know, how the person is managing their job and how the accommodations are working. And if they're running into sort of any novel problems, then often a touch base can be helpful.
Great, thank you. Yeah, and it's good to know that sometimes just a session or a few number of sessions can help people in that return.
Yeah, definitely. I just actually had someone return, and I think I did 6 sessions, and she's now taking it. She was, you know, well on her way, doing part-time many hours, and was just going to finish that off on her own. So I'm assuming it's going well because I haven't heard from her.
That's great. That's great to hear. Any other questions? I'm not seeing any more in the Q&A. And I do want to apologize. There was some confusion about tonight's talk. There had been a switching, my apologies, of the sleep talk and the work talk. So for those of you, and I had responded in the Q&A and I think in the chat as well, just to let you know that we are going to have Dr. Neil Parekh, who's going to be talking on sleep issues in 2 weeks, May 30th at 6 p.m. So you can tune in then for the live version. And as I noted previously, if you're not available, they're all recorded. So you can always just watch them at your convenience. Okay, here's a question. Any research on increased symptoms or prolonged recovery when returning to work too early, and because of that, not staying below symptom threshold? I feel like that's what I'm experiencing.
Okay, yeah, thank you for the question. That's a really good question. I think if we look at returning to any activity, and work is one activity, if the symptoms progress to the point that I would say like it wrecks your night or it spills into the next day, we know that that is, is too much. I find most people do have some increased symptoms when they return to work because of the increased activity level. And so that's where we look at that settling down before we look at increasing the hours. So I think it's common that when people return to work, they do have increased symptoms. But if it was to the extent that they, for example, couldn't get out of bed the next day, then we know we've probably gone too quickly and we need to back up a little bit and rethink this process. So that's helpful.
Okay, thank you. And Yonica, and I apologize, I think technically something went down with the few questions that had been there. And I think this is another one of them, is asking, can you say something about the likelihood after years and repeated concussions? And then in brackets, the graph looked like 104 weeks equals close to 0. And she's just saying that's disheartening when you give hope.
Yeah, thank you. That does certainly sound disheartening, doesn't it? So those graphs are pulled from the research, but we need to remember that it doesn't mean that everybody falls into that bucket. I do know that I personally have worked with people who have been off. The woman that I was just telling you about, who I did 6 sessions with, she's almost 2 years out right now and is rapidly going back. So certainly it can happen. And I would never want someone to think that it's not ever possible. Sometimes I've had people I've worked with where we've had to think about changes in position or changes in job to make things work, which is never anybody's first choice. But people generally want to work. It's really important to us, and it's really good for our mental health. So I would say that, yeah, there still is a possibility, despite what the research shows, because I have seen some people who have returned. So I hope that is helpful.
Great, thank you. We have another question. What kind of accommodation can be recommended for letter and number flipping? I'm assuming this person mistakes letters and numbers. I have been unemployed for over 8 months and indicates they were harassed at work. And because I have a mobility device, I have faced discrimination in finding a new job. Am I better to try and change fields? I have been a medical secretary for over 18 years. I don't have access to an occupational therapist. I'm wondering if you can comment on that.
Well, that is a tough situation. I'm sorry to hear that. So I think, starting off, if I recall, was with the letter and number flipping. That certainly is a really specific issue. So it sort of might depend on what the cause is. I think I'm finding that a little bit hard to answer. I have had some clients who've had some difficulties along that line, and they've worked with, for example, a speech pathologist to work on that. I don't, it possibly could be a visual perceptual thing. So it might depend on sort of what is causing that. So I'm sorry that I can't answer that more specifically. And Leslie, I can't remember what the end of that question was.
Yeah. Yeah, and Yannick just volunteered that vision therapy had helped with the letter number flipping.
Excellent.
She was asking if she's better to try and change fields, and doesn't have access to an occupational therapist.
Right. So again, changing fields, that would be hard after 18 years, if I recall, at your job. And I think, depends, I would say, on whether that letter and number flipping can be sorted out, because as a medical secretary, obviously that would significantly impact your ability to do your work. So if that can be resolved in any way, then that would certainly make it more plausible to return as a medical secretary. If not, then it might be more proactive to consider a change.
Okay, great. Thanks, Leslie.
Mm-hmm.
Question, how much does it cost to have an OT and who pays?
How much does it cost to have an OT?
Yeah. And who pays for it? Is it, is it covered by OHIP? Yeah.
So cost would vary depending on where the service comes from. Outpatient OT for this kind of work would not be covered by OHIP. I'm finding more and more extended health carriers are providing some coverage, but I would say it's still nowhere near as thorough coverage as you would find for like physiotherapy or mental health counseling. So I always say to people, check your policy really carefully. Sometimes nowadays they're giving a set amount that you can use for any paramedical provider. They usually lump them under that on the policies. So that would be where you would look, because otherwise it would end up being an out-of-pocket expense. And of course, we know that any therapy out of pocket can get expensive really quickly, unfortunately.
Okay, thanks, Leslie.
Mhm.
Jen is asking, how do you approach employers of more like factory type workers with concussion issues? My experience is if a person can't do the job right away, they are fired or pushed out of the job.
Yeah, good question, Jen. That's for sure a tricky one. I have had some situations where they will accommodate the person, so they'll completely switch what they're doing. You know, if they're a factory worker and it's on a line, for example, and they have attentional lags, that's not going to be compatible with working on the line. So I've certainly had some employers who've been willing to give the person another job for a while, but at the end of the day, they need to be able to work back to that position, and if not, I've also seen the same situation. And I've understood from employment lawyers I've spoken to in the past that the employer does have the right to do that under certain circumstances, which is disheartening. But some of those positions, for example, I had one individual who with the specific job that they had on the line, it involved a fair bit of vibration, and that was just not tolerable over time, so they could not return. So I'd say my experience has been a bit varied, but it does depend on the employer quite a bit.
Okay, great, thank you. For desk jobs, is there a computer which works best?
So in my experience, I would say no, and I'm saying that because I've seen the gamut. I've seen people who prefer a really large screen because they find that really helpful, and I found some others who find a very small, compact screen very helpful. So I don't think there's any specific type. I think what's important is what works for the individual, and then also, as I mentioned, during the talk, to consider the ergonomics, because many people with headaches, for example, might be using a really awkward neck position, and many employers will have that available. So I often say to people, ask if there's anyone within the company who can do an ergonomic assessment and give some. And I've had some great success with that, where people can get things set up better for them. So no, I don't know a specific computer that works best, though. It's not a one computer fits all.
Okay, thank you. Steph asks, is the OT consult available via McMaster Health Sciences ABI outpatient clinic covered, or is that fee for service?
Thanks for the question, Steph. So I didn't know McMaster had an OT consult through their ABI outpatient clinic. Certainly at Hamilton Health Sciences, they do have an integrated adult concussion clinic, but it does not have an OT attached to it. The OTs in the adult program, of course, work on the inpatient units, but I'm not aware, so I'm sorry if there is one I'm not aware, but I've been associated with McMaster for a long time, but I'm not aware of that service.
Steph just said, sorry, I meant Hamilton Health Sciences.
Oh, yeah. So Hamilton Health Sciences, so their adult integrated concussion clinic does not have an OT. You would see an intake person and then a physician, and then they would make referrals from there, but they don't actually have allied health professionals, any physio or whatnot associated with it.
Okay, great, thank you. Here's a question. Can you ask an employer to change the fluorescent lights?
So you can always ask. I never think to ask. And I have had people ask, and depending on the work environment, I had one individual where because her office was a separate office, they were able to change that. I have had people where they've moved their office to allow them to sit near a window and bring in a desk lamp that then has to get checked out by whoever checks out electrical equipment. And I have had different employers do different things. So yes, it is possible and always worth asking. So good question.
Yeah, absolutely. But yeah, there can be quite a lot of variability, I think, in terms of how agreeable the employer is. Steph, just a follow-up, said, okay, thanks, about the Hamilton Health Sciences. He said that he or she said that their referral form has an OT option on it. So
okay, well, there you go. So probably
you never know.
Yeah, you never know, and probably the best thing would be to ask them directly then. Yeah.
Great, thank you. Mike is asking, is it known if noise canceling headphones at work will help in a return to work, as many people with a TBI don't tolerate noise very well?
Yeah, that's a good question, Mike. And certainly I know many people who use noise canceling headphones or different forms of earplugs to help them at work for exactly that reason. And I've had some people now, of course, I'm not an audiologist, so I don't know about specifics of this technology, but I have had a number of patients who use what they call musicians' earplugs. And they describe that it blocks out the background noise, but allows them to hear the person they're talking to. So I have different people that I've worked with, different patients who've used any of the above.
Great, thank you.
Mhm.
Okay. I think that brings us to the end of the questions. And we are almost at time. So, and Zoe, oh, thank you very much, Zoe. Zoe has just posted a link that you can use to actually search for an occupational therapist in Ontario, and indicates this probably would be fee for service.
Oh, that's great. Thank you.
very
Yeah, I can see that that
helpful.
is through the college, not our provincial body. So thank you.
Okay, okay. And Yonica said, yes, Calmer and Vibes earplugs are great. Okay, thank you. It's always good to hear something that works. So
That's right.
yeah, well, Leslie, thank you so much. We really appreciate you returning. It was an excellent talk, and my apologies for some of the glitches tonight. As I mentioned earlier, we have our sleep talk, which will be our last for the spring, and then we'll be taking a bit of a break and returning in September. So we're going to have Dr. Neil Parekh with us on May 30th. And Christian has very kindly put in the link to where you can find all of the recorded webinars if there's anything you want to take a look at. And I will just finally say, if you have a minute or two, we always really appreciate if you can fill out our survey just to provide any feedback, suggestions that you may have for us. So hope you have a good couple of weeks and a nice long weekend, and have a great night, everyone. Thanks again, Leslie.
Thank you.
Take care.